My name is Jabir Bhatt. I'm Chief Executive of the Race Equality Foundation. The foundation is a Black, Asian, and minority ethnic-led charity that uses evidence to challenge systemic racism. And we're the organization that's been working with a number of colleagues to run this webinar, but also to develop the recommendations that are going to be a focus of today's conversation. So hopefully you're all here for the launch of the co-produced recommendations to accompany the Institute of Health Equity Evidence Review on Structural Racism. We're really pleased to have Dr. Jessica Allen here with us today, who's going to run through some of that evidence and hopefully give us an opportunity to better understand the background to the work that we did in co-producing the recommendations. Importantly, we've got other colleagues here as well. Tracy Bicknell's going to, my colleague from the foundation, is going to talk to us about how the recommendations were developed. But we've also got Tumu Johnson here and Sophia Makano, who are going to talk about their involvement in the co-production process as well, and perhaps raise some challenges that we've got to address as well. If I can get the housekeeping slide up. So hopefully you can all see the housekeeping slide. It's just to remind everyone about that the webinar is being recorded. Hopefully you'll realize it's just so that we can share some of the conversations that we've had. Please ask questions via the Q&A function, and hopefully you can all see that on your Zoom screen. If you're having any IT issues, do the technical thing of logging out and logging back in again, and hopefully that should resolve all those issues. Could we move to the next slide? As I said, we're going to have we're launching the co-produced recommendations today, and a key part of that is to try and understand the background to this work stream. And we're really pleased to have Karen Stedman with us today, the Senior Manager on Health Inequalities from Greater London Authority, who commissioned the original Institute for Health Equity Evidence Review, but also commissioned our work on developing the co-produced recommendations. As I've mentioned, we've got Dr. Jessica Allen, who's the Deputy Director of the Institute for Health Equity and works very closely with Sir Michael Marmot, who's led on the evidence review, and Jessica will try and talk us through some of the key messages. Hopefully it'll encourage you to actually go and look at the whole of the review, because it's a really very vital piece of work and there's lots of evidence in there as well. Tracy Bignell, my colleague, who's the Director of Policy and Engagement at the Foundation, is then going to talk to you about developing the co-produced recommendations, the process we went through, and also then highlighting some of the recommendations themselves. Today is the first day that it's going to be made publicly available, so please do go and look at what's quite a comprehensive document as well. Importantly, we've got Tumu Johnson, who's from the design working group, who was intimately involved in the development of those recommendations, and she'll hopefully raise some of the challenges of being involved, but also some of the challenges to the recommendations as well. We've got an opportunity to address some questions at that point before we move on to a hearing from Safia Marcano from the Association of Directors of Public Health in London. She's the program manager there on tackling racism and inequality program. She's going to focus on aligning with the wider anti-racism work in public health. We'll end with you're coming back to me with us trying to think about what some of the next steps are and hopefully a call to action. If I can take just my last couple of minutes to provide a bit of a background from the foundation. Choosing June the 30th, we didn't have any crystal ball in deciding on this date. It was, as is always the case with these things, a compromise as to who's available on what day and when will we get all the work done. But it's turned out to be a really significant point to be launching these recommendations. Last Wednesday, we had the Secretary of State for Health speaking about health inequalities and what this government planned to do at this stage in terms of addressing health inequalities. He not only announced the £2.2 billion that's going to be invested in tackling those inequalities, including the inequalities faced by black men with prostate cancer, as well as black women in maternity care. But he also talked about revising the formula, the Cahill formula, which is fundamental to the way money is distributed. Some of you will remember back when the NHS long-term plan was being developed and announced, we argued that that formula needed to be revised to take better account of the inequalities, health inequalities being faced by Black, Asian, and minority ethnic communities. Many of you will know that the GP practices that are most likely to be serving those communities in London tend to have received less money per head than those practices in comparatively richer areas such as Surrey and so on. Many of you will have seen during COVID-19 that the distribution of the vaccine was slower in places like Lambeth, Lewisham, Tower Hamlets than it was in other places as well. And that inequality inevitably leads to poorer experiences and poorer outcomes. What's obviously to be hoped is that the 10-year plan, when it's launched later this week, builds on what was announced last week and really integrates tackling racial inequality into that plan. But these national developments are just provide the context within which we're meeting here today. London's 3.6, 3.7 Black, Asian, and minority ethnic Londoners is what we're really interested in talking about today. They constitute about 46% of London's population. And while London continues to be one of the richest places in the world, not only in the UK, in the world, it is the case that Black, Asian, and minority ethnic people in London continue to experience racial inequality. And that racial inequality manifests itself in various ways, whether it's lower rates of employment amongst those communities, whether it's the greater risk of being in jobs that are 0-hour contracts. That racial inequality is live and kicking. But hopefully what you hear today is not only the evidence on inequality, but also some of the things that can be done to address it. As importantly, what you hear is that for that to be successful, you have to bring an intersectional lens to those understandings. We need to see Black, Asian, and minority ethnic people in their roundest form, recognizing that disability, sexuality, age, and other factors play a part in their daily experience, and any successful approach to challenging that needs to address it. What we're now going to do is move on and hear from Karen Stedman, who can commission the original review and also commission the recommendations. Over to you, Karen.
Thank you so much, Jabir. So as Jabir said, I'm Karen Stedman. I'm Senior Manager for Health Inequalities at the GLA, and I just wanted to come today to speak briefly on behalf of the Mayor of London and the GLA, who, as Jabir said, grant funded the Institute for Health Equity Evidence Review on Structural Racism, Ethnicity and Health Inequalities, which was part of a series of reviews on health inequalities and the evidence base in London, and also funded this linked co-production work, which is the focus of today. I really wanted to start by saying thank you to the Race Equality Foundation for leading the co-production process, and to all the organisations and individuals who are involved in that process across voluntary community sector, statutory sector, and those who shared their individual lived experience to contribute to the project. This is a really important area for the GLA, for the Mayor, and for London generally. You know, the Mayor's vision is for a healthier, fairer city, and the GLA is focused on tackling health inequalities as well as equity distinctly and generally, and specifically thinking about race equity as well. And we recognise certainly in health inequalities that race equity is an area that's been overlooked for far too long, and hoping to kind of accelerate action to try to really, you know, cover some ground through focusing on this as much as possible. We resourced these pieces of work in the GLA as we wanted to make sure, working with the IHE in particular, that the evidence was as kind of tight and clear as it could be about how racism and health inequalities intersect in a way that could be widely used in London, but also beyond. And Jessica will speak to that in more detail and what their work has achieved. The co-production work, specifically the focus today, was because we wanted to create something for London that built off that evidence, but spoke to the priorities and the reality of the city that we live in. So listening to what people who've experienced structural racism want to see, and reflecting on the levers and opportunities that we have within our London system. I'm pleased to say that, you know, there's been quite a lot of progress already in the GLA on the areas raised for us in the report. And I know also that there's lots of different organisations who will be the focus of these recommendations, who are also, you know, doing lots of focused effort on race equity in their own jurisdictions. I'm not saying that there isn't more to be done, there is, but I also know that colleagues certainly across the health and care system are committed to taking forward action on race equity. And that's in the NHS, in London's ICBs, in local authorities, and in public health. And Safia will speak to some of that as well from a public health perspective. The GLA is also working with partners where we can to support race equity as a health inequalities priority in London. We recently published a new, and I'll speak about health inequalities a lot because that's my specific area, but the GLA does actually look at it from a range of different angles. But we recently published an implementation plan for the London Health Inequalities Strategy. So the Mayor of London has a statutory duty to do a health inequality strategy for London, but we've just produced the plan that sets out the Mayor's commitments for this term. And that includes, I was very, very pleased to be able to say, a continued announcement for health and race equity through the London Anti-Racism Collaboration for Health project, which continues to be a key commitment in the Mayor's Health and Equality Strategy programme. I won't go into detail on the LARCH, but we'll signpost to the website. I'm sure Race Equality Foundation colleagues will do as well. But the LARCH collaboration involves investing resource and energy in London across London's health and care system in promoting and accelerating action on race equity within health and care organisations. So looking at how, you know, we can champion and support what's happening in individual organisations, and how by coming together across those organisations we can go faster by challenging each other, learning and sharing more together. And some of the recommendations that you'll hear about today will be picked up through that LARCH, London Anti-Racism Collaboration for Health, or LARCH, work, as well as through individual organisations. I just wanted to flag as well, much like Jabir did, that this is a time of change, and obviously that does have implications for work such as this. The NHS plan is out very shortly, which we, you know, setting a new direction. And there's also, of course, the reforms to ICBs in NHS England. It causes a lot of strain in the system, and of course there's a continuing difficult economic climate for organisations as well as for Londoners. And it's part of our job in the LARCH to kind of keep advocating and bring leaders together to make sure that we're still doing what we can to ensure that race equity remains central to our work in London, and that it doesn't get forgotten or lost in all the change that's happening. I think it's also important to recognise that, you know, and this is part of the function of the LARCH as well, that with lots of change comes lots of opportunities. And, you know, part of our role is to make sure that we're keeping an eye out for those opportunities and making the most of them when we come, to make sure that race equity is embedded as a crucial part of tackling health inequalities in London. That's all I wanted to say. So thank you very much for your time, and hope you enjoy the rest of the webinar.
Thank you for that, Karen. And I can't let this moment pass without pointing out that Karen's moving on to other things at the GLA as well. Hopefully the interest in health inequalities will remain, and we'll be able to engage her. But we do need to thank her for all the efforts that she's put in over the last few years to ensure that health inequalities doesn't fall off the agenda. We're now going to move on and hear from Dr. Jessica Allen, who was part of the team that produced the review of evidence on structural racism. Over to you, Jessica.
Great, many thanks. And I'm so pleased to be here and for these discussions about these co-produced recommendations. I think it's such an essential part of the process. We were, as Jabir said, synthesizing and overviewing the evidence. We did develop recommendations, which were quite high level. So to have had all the co-production that's gone on subsequently, I think is such a statement and great progress. So delighted to be here, and thank you for the invitation. I'll just run through quickly some of the key points from the report, but as Jabir said, it's a long report, it's very detailed. Don't be put off. It's hopefully a very useful resource, and certainly we've had a lot of interest in the report from outside London as well, and many public health local authority teams are picking up the report and beginning to explore these critical issues in their areas as well. So it's having an impact outside of London as well. Thank you. Next slide, please. Slide. So as Karen has said and Jabir said, the report was commissioned by the GLA. And I think part of the reason for the commission was to really highlight how structural racism impacts on health in multiple ways. And it's not an area where public health has really led hitherto, maybe more in London and in other places, but I think it's really important that public health takes on the whole agenda about how structural racism impacts on health and tries to work to tackle it. And as I say, outside of London, that's not been a particularly strong feature. So we developed recommendations for action across London and inform public health and other stakeholders. So I'll have the next slide, please. That's the cover of the report there. So for the report, we overviewed inequalities in health related to ethnicity where we can. Lots of caveats throughout the report about the data and what's available and where there should be more data, but we did do an overview of what we could to show inequalities in health related to ethnicity, as well as to poverty, socioeconomic position, gender, disability, and so on. And as has already been highlighted, there's a lot of intersection in the outcomes that we see in health. And then we also overviewed inequalities related to ethnicity in all these 8, what become known as the Marmot principles, which are really a way of summarising the drivers of health that affect all of us and affect all of our health. So from giving every child the best start in life through education, young people, through the working life, the importance of having sufficient income, principle 4, 5, housing, places, transport, criminal justice, all critical issues, of course, across London, shape everybody's health, and particularly for some of minority ethnic groups. Role and impact of ill health prevention, that's more related to more traditional public health, I guess, around alcohol, smoking, obesity, drugs, and so on. This 7th principle, by the way, obviously this directly relates to what we're discussing this afternoon. The first 6 principles are the same as were in a report in 2010, which is known as the Marmot Review, which was a national report across England looking at, commissioned by the government, looking at health and what's shaping everybody's health and health inequalities. Principles 7 and 8 we added subsequently, much needed, but around tackling racism, discrimination and their outcomes and how that impacts on health, and then environmental sustainability. So these 8 principles feature in our report, and we, as I say, we overview inequalities related to ethnicity, socioeconomic position and so on in each of these 8 principles. Next slide, and make recommendations in them as well. So this is the percent of children living in low-income households after housing costs. Absolutely staggeringly high rates of child poverty among some households, Pakistani, Bangladeshi households, with rates of poverty in London of 70% after housing costs. Extraordinarily high rates of poverty. The average for England around 30, that's incredibly high, as it is, nearly a third of children living in poverty. But among these households here, some Black, other Asian, Pakistani, Bangladeshi households, such high rates of poverty, which of course impacts on children's health in the short term when they're children, but also throughout the rest of their lives. So clearly efforts to reduce poverty need to have this ethnicity lens as well, to make sure that their action is proportionate to the scale, really, in these among these ethnic groups. I mean, Chinese, still a fifth of Chinese and white and Indian households, children in poverty. Next slide, please. And you can see these very steep inequalities in education between free school meal children, which is the darker green bar, so children eligible for free school meals and those not. And you can see that for every ethnic group listed here, children who are not known to be free school meal eligible have better outcomes. But you can also see among free school meal children, these big ethnic differences related to ethnicity. Gypsy, Roma, Irish traveller, Irish along the bottom here, white British. Now this is important because Chinese, Bangladeshi, Indian, Black African, all these ethnic groupings up here towards the top are doing really well, relatively well, in relation to free school meal children's doing well at school. And this was a feature actually of the evidence that in data that we overviewed, that despite some of the racism that we documented that children can experience at school, their educational attainment is really good, certainly compared to similar households outside London and some of these other groups down here. Next slide, please. However, when you get into employment, these inequalities seem to almost reverse. So Irish, Chinese, mixed white age, Indian, much higher rates of employment for both men and women, and Bangladeshi, Pakistani, Arab, much lower rates of employment for both men and women. So despite doing really well at school, getting pretty high levels of attainment, the position reverses in relation to employment. Something quite significant is happening here in London. It's, by the way, again, different outside of London, but the position is reversed. So employees, and then we looked at recruitment, retention, progression, pay, and saw how profound these inequalities are related to ethnicity in employment. Next slide, please. So here you can see pay, again, Bangladeshi, Pakistani, Black Capital, much lower rates of pay down here, and the same groups, Chinese, Indian, white Irish, white British, white other, much higher rates of pay. So again, referring back to attainment, this isn't a lack of skills or a lack of educational attainment that's driving these inequalities. It's down to discrimination and racism, probably among employers in London. Next slide, please. There's a lot of data in the main report, so please do, if you can, have a look at that main report. And you see in every area that we looked at, we saw big inequalities related to ethnicity in relation to employment, pay, obviously the criminal justice system, quality of housing. Here we're looking at the impact in the reduction in benefits between 2011 and 2020. So every group has had a reduction in the level of benefits that they receive, but particularly it's affected Black households, mixed households, and white the least. And we saw this time and time again, how these changes in benefits and in pay and so on had affected these households more. Next slide, please.
2 minutes.
Yeah, so we've developed a lot of recommendations in all these areas, in these MAMA areas. We noted reams of good practice, lots of good case studies. We put a lot in the report, but much more is needed, and it needs to be much more systematic. So the recommendations are quite high level for the system in London and national policymakers. They focus on sort of structures and institutions, and how that can lead to inequalities and disadvantage. We try to focus specifically on programs, for example, to reduce child poverty, but focusing more on those ethnic groups which are most disadvantaged. So having programs which are proportionate to the scale of need among particular ethnic groups, and how services, and you'll be very well aware of healthcare services and so on, need to be much more culturally aware and delivered appropriately. Next slide, please. And we also, we made the case about public health to take a leading role in highlighting the impacts of racism on health, which it hasn't done, I wouldn't say routinely everywhere, and putting racial equity at the heart of policies and interventions, spending and resource allocations, as I've said, proportionate to the scale of inequities, culturally appropriate services. And we focus quite a lot on accountability mechanisms and sanctions, because when we overviewed the evidence around how well equalities legislation was working, EDI policies and programs, they were found to be really woefully inadequate to the scale of the task. They weren't protecting communities against discrimination and racism. They weren't, it required a lot of effort from individuals to be proactive and report and drive through a very difficult and technical system. So we talked a lot about strengthening accountability for racism and appropriate sanctions. And then we made recommendations around the need for more data and evidence to highlight the scale of the issues, and also to inform the system and allow evaluation of their impacts. I think that was my final slide.
Thank you for that, Jessica.
Thank you.
Lots of information to get through, and
Yeah.
done very succinctly. Thank you for that. We're going to have an opportunity to deal with questions in a short while, but what we wanted to hear first was from Tumu Johnson, who played a key part in the design working group that produced that helped co-produce the recommendations. Over to you, Tumu.
Thank you, Jabir. Hi, my name's Tumu, and I use she, her pronouns. I'm just going to give a brief visual description for access purposes. I'm a disabled woman of black mixed heritage, and I'm wearing pink with pink earrings, and I use a wheelchair. I wanted to speak about the experience of being involved as a person with lived experience of the healthcare system since birth. I live with a chronic neuromuscular condition, and as I said, I use a wheelchair, and I have 24-hour care support via continuing healthcare. And I guess I just wanted to say that we are all multitudes, which has kind of informed some of the ways that we've thought about these recommendations. So it's kind of hard to take off my other hats in the process, but I guess I've been trying to think about, my experiences within health. And I guess all of us are likely to use health services to differing degrees throughout our lives. So even kind of my experience now is really maybe useful, but other people will have other experiences going forward. So for me, intersectionality felt really essential to this work. So my view is that we can't talk about health without talking about disability. And we can't talk about disability without talking about ableism. So health services, constructs of wellness and quality of life are so often reliant on an ableist narrative of normativity. So I was kind of came to the sessions thinking about what can we learn from disability that will enrich our anti-racist lens. Felt like I was among a lot of experts. And so I was kind of taking that angle, what can we add from what we know about disability, and how will that help us to reach those on the margins who are deserving of access to healthcare in a dignified and safe way. So we had lots of discussions, and thanks to the chair of the meeting, because it was no small task to hold that many people in the room with such rich contributions. And I wanted to one thing that happened for me kind of recurring was thinking about a topic together and then kind of me feeling quite strongly that we needed to name ableism within that. So I'm going to read out the overarching principle that we kind of agreed upon, which is at the beginning of the recommendations when you read through the document. So it says all organisations involved in the commissioning and delivery of health and care services and other areas which have an impact on the health and well-being of communities need to acknowledge that experiences of ableism and racism are often intertwined, and that a focus on racism needs to consider intersecting factors when taking an anti-racism approach. So it says, whilst ableism is not specifically mentioned throughout, the intention is that where racism is mentioned on its own, the recommendation must address other discriminations that intersect with it, including ableism. So to explicitly have this as a frame felt important to me, as so often we'd be discussing something and the links to ableism would be glaring. So I had a worry, and I still have a worry maybe, that ableism not being named throughout might mean that some people do forget to kind of consider it in their thinking. So during the process, yeah, I learned a lot from a lot of different experiences that people were bringing to the working group, and it helped me to kind of reflect on my own. And I kind of was often left with this feeling that it's so impossible to detangle racism from ableism when accessing healthcare for me personally. And an example of this, we spoke about the often inadequate healthcare that people with sickle cell disease receive in this country. And we know that that's driven by structural racism and that it causes added levels of distress and death. And at that time, amongst others, and kind of through my personal loved ones' experiences, I was kind of left thinking about how I think we're quite good at identifying how racism exists within that experience, but maybe less so how ableism comes into it. So kind of heavy on my mind was the story of Evan Smith, who was a 21-year-old man who went into a sickle cell crisis and resorted to calling 999 from his hospital bed to try and get the medical help he needed. And he died, sadly, and the coroner cited insufficient staff training in managing sickle cell, especially when experiencing crisis, and that contributed to his death. And I guess this is an example of the sharp end of structural racism. But if we broaden our view day to day, the impacts of ableism as well as racism also impact people living with sickle cell on a daily basis, and likely contribute to poor health. So kind of a disbelief of their pain, accusations of drug seeking, delayed care. We know the stories, but something that we spoke about and that's been highlighted in the recommendations, for example, is that they don't automatically qualify for free prescriptions. And for me, this is like a glaring example of like these things intersecting, and something that the Sickle Cell Society has been campaigning for a long time. And if we think about what we know about disability, we know that it costs approximately £1,000 per month on average more to live as a disabled person in the UK than non-disabled counterparts. And we know that poverty is a social determinant of health and a cause of the causes. So steps to reduce the financial burden of disability and sickness are essential as preventative measures, as well as looking at the racism. And so the overarching principle of this recommendation calls us to think about ableism as an intersecting oppression that is intertwined with racism at every step of the way. And many of the recommendations call for the health and care sector, local authorities and voluntary sector to work together and to co-produce. And this kind of invites us to think about how racism and ableism show up in the wider context. So I think the last thing I kind of wanted to talk about was just that kind of as people interested in health equity, my view is that we should be keenly listening to disabled people and activists who are warning of the kind of detrimental and potentially deadly impact of the proposals around personal independent payments. And Jessica importantly mentioned how benefit receipt and changes to benefits kind of unequally affects people along ethnic or racial lines. And it kind of leads me to think closely about inequities that we know exist in healthcare and how that might shape the use of something like the assisted dying bill in this country. So this has been a really valuable experience for me to be involved in the working group. And I've been really grateful to be involved. I think it's kind of made my brain go like a bit wild, because it made me think of so many different areas. And I think we realized it was really hard to kind of drill down on so many areas that we knew were like equally as important as each other. So I think it's reading the document, I'm really impressed with how clear and accessible it is, given how much content there was like in the room. And I just wanted to say thank you for everyone's hard work, and I hope that the recommendations are useful and effective, I guess, in progressing anti-racism work across health. And I guess my hope is that along with other intersections, because obviously there are many, as Jabir mentioned, and it's not to say that disability is the only one, but I think within a health context, ableism does dominate. And so I think we really need to include that in our thinking. And I think we have attempted to do this in the recommendations, but still always further we can go. So thank you.
Thank you, Tumu, and thank you for being very gracious and not pointing out that I'd made an error in the program and brought you forward, but you've spoken really very well. And as importantly, the challenge you posed during the co-production process is one that comes through very clearly today. We're now going to hear from Tracy Bignell, both about the process of development, but also the recommendations themselves. Tracy, over to you.
Thanks, Jabir, and thank Tumu for what you said about the recommendations there. It was a very interesting discussions we had where we were co-producing them. Next slide, please. So I'm going to firstly talk about the process, how we develop the recommendations. So this was a multi-staged approach over around 6-month period. We had a core group, which is the design working group, and that was made of equal representations of people with lived experience, the health and care sector, so for example, London councils, and also the voluntary community sector. So we had organisations who worked with specific ethnic groups, so the Somali community, as well as working around a specific inequality area, so around disability. And what we were tasked to do at that time was look at the initial draft of the recommendations, the initial task of the review that Institute of Health Equity had produced. Next slide, please. So Jessica was very gracious and helped us out quite a bit by attending a couple of meetings to help people really engage with the evidence from the review, so they really understood how the conclusions were being drawn. So the core design working group initially started by exploring the evidence in the initial draft of the review. One of the first things that the group did was identify some gaps, and this was where there were areas they expected to have mention, but it may be because there wasn't sufficient evidence to mention in the review at the time. So for example, unpaid carers, and we know about the health and well-being of unpaid carers, and also how they have issues accessing support and gaining the right support. There was also discussion around racism in schools, particularly in relation to how schools recorded but not necessarily acted on racism experienced by pupils and teachers, and also concern that there wasn't really much around older people, but yet we know that Black and minority ethnic communities is an Asian population. We also know that some groups are at higher risk of developing particular conditions like dementia, but may not necessarily have that diagnosis and get the relevant support. So these were some of the issues that were originally identified. Tumu has already talked about intersectionality, and that was very much part of the discussion, looking at an intersectional approach, looking at different vulnerabilities and how they intersect with the experience of racism. There was also a lot of discussion around data and the limitations of data. So, for example, in terms of whether specific areas, so if we look at mental health assessment, whether ethnicity is actually recorded, but also around the quality of the data. So the categories that are used, are they relevant? Are they up to date? Do they reflect the actual population of London? So there's lots of discussion around data and what that would tell us in terms of the evidence. And this led us to develop an overarching principle, which Tumu has already talked about, and that was how we can look at ensuring that intersectional issues, particularly looking at ableism and racism, would not be ignored, essentially. And while we were starting to draft the recommendations, one of the first things we looked at was what was happening in terms of the existing recommendation across different areas. So, for example, criminal justice. So how many aspects of the Lamy review have been implemented? How many aspects of the post-send review had been implemented? And really looking at whether there needs to be a new recommendation developed on perhaps supporting young people with special educational needs and disability, or whether existing recommendations actually cover what it is that the design working group hoped would cover. Next slide, please. So what the design working group decided was that we should take a life course approach when looking at how we can develop the recommendations for the Institute of Health Equity Evidence Review. And because we know that racism has a cumulative effect, and we know that that affects you across the lifespan, this approach was felt to be really relevant. So it's an approach, a framework by the World Health Organization, and it's really looking at how you can look at different stages across the lifespan and try and put interventions in place where you minimize risk factors. So minimize, for example, violence or crime and so on, and actually enhance protective factors. So factors around education, and different health evidence-based interventions that are put in place at these different key life stages. And it could be a stage where you've got a young child starting school, it could be you become a parent, it could be throughout your working life. So looking at these key stages where an intervention could be put in place to have real impact on people's life span in terms of their health and well-being. So essentially trying to lessen negative impact of the wider determinants of health and racial inequality, and trying to promote good health and well-being. Next slide, please. So in terms of the life course approach, the recommendations that were developed were divided into 4 areas. So we have starting well, which is around preconception through to young people up to the age of 25. Living well, which really is for working age people. Recovering well, so looking at long-term health conditions and also mental health. And aging well, supporting older people to age well and to be healthier for longer. Taken on board these key life course stages, some recommendations were drafted, and we also looked at existing recommendations and tried to see whether or not we needed to devise some new ones. We go to the next slide, please. So just to explain, on the left-hand side, those were the main areas of the initial draft of the review that we looked at. And then after discussions within the design working group and from their expertise and from people's experiences, these were the additional areas that the design working group felt that we needed to cover in terms of co-producing recommendations. So essentially, there were areas that were not originally in the draft reviews, such as mental health and aging well, and these were the areas which were now included in the co-produced recommendations. Next slide, please. So the design working group, we wrote them up, and essentially there were 4 meetings which really focused on each of the life stages. So this was really looking at the draft recommendation that had originally been devised by the design working group, and to see whether or not they were appropriate for that particular life course stage. So it was exploring whether a recommendation actually covered the issue, whether it aligned with the evidence around what we know about the experience of Black, Asian and minority ethnic communities. Importantly, whether the organisations that are accountable or deemed to be accountable for recommendations were the right one, and whether the phrasing of these draft recommendations were right. Were they clear enough? Did they actually get across the meaning of what action needed to be put in place? Next slide, please. Just to say, we had 52 recommendations by this stage. This is an example of one of the draft recommendations that was produced around criminal justice. So essentially, it's talking about implementing the recommendations from previous reviews where there were elements that had not yet been implemented. Next slide, please. So once the 52 recommendations were drafted, we then had wider engagement, and this was through an online survey and also through 2 engagement workshops. So essentially, there were 85 organisations who took part in the process. We had a number from the statutory sector, a number from the voluntary community sector, quite a number of lived experience, and academics responded to the engagement. And what we really wanted to know was whether or not, you know, participants would endorse or reject a recommendation. If we had one around mental health, was this a right recommendation? Was there something else we need to think about? But as importantly, how could we prioritise the recommendations? 52 is a lot of recommendations. Next slide, please. So this is just a bit of an overview of some of the responses to the draft recommendations. I have to say, we actually ended up with suggestions for more recommendations, despite already having 52. So we were told some of the recommendations were too broad. They need to be more specific. They need to be more assertive. They need to be bolder. Where there are recommendations and perhaps some participants felt it wasn't clear enough, that there should be supporting documents so you could find out where the recommendations, what was underneath and what actually drove the development of a particular recommendation. I know accountability has been mentioned a few times, and it's really that we can have numerous recommendations, but if the organisation isn't accountable, what happens with the recommendation? So there was a strong emphasis that there needed to be accountability in any recommendations that was put forward. And in terms of implementation, there were different suggestions. Should there be targets? Should there be short, medium and long-term targets? Should there be recommendations targeted at the national level, local level, the region and across London? So there were lots of different suggestions as how the recommendations should actually be when we finalise them. And as I said already, everyone found them very difficult to prioritise. And I think probably because the number of recommendations that covered all the different areas from a young child through to older age, that everyone felt it was important because there wasn't enough action and people didn't actually see any changes in outcomes. There was a real urgency that something needed to happen, and it needed to happen quite quickly. So the quote there is from a respondent who talked about the fact that we have numerous recommendations, but we really needed collaboration. We needed organisations to work together in order to implement this across London. Next slide, please. So there was further revision of the recommendation, a further discussion, and a template was developed to try and make each recommendation clearer. So it had a strategic aim, so the goal we were trying to achieve under a particular theme. It had an objective. It had, clarity as the organisation or the sector that the recommendation referred to, and the specific actions that needed to be put in place in order for the recommendation to be effective and to be implemented. The quote is from someone from the statutory sector who participated in the second workshop that we had, where we revised the recommendations. We used this template, and they felt it was much better. The framework helped people to discuss the recommendation. There was a lot of clarity, and people understood what the intention was around a particular recommendation. I'm going to stop talking about the process now, because that's essentially where we got to, and we then revised the recommendations and came up with the final amount. So I'm now going to move on to the next slide. So in a slightly different order. So in terms of the structured template that we had when we revised the recommendations, we were essentially asking, does the framework capture recommendations in a better way than they had previously? whether the recommendation is more deliverable, if it's in this kind of template, and the organisation that is specified, are they the right organisation to take forward a specific recommendation? So the final co-produced recommendations actually total 64. We started with 52, it went up to 60 after all the engagement and consultation, and we have 64 total recommendations. And I know Tumid mentioned earlier on the issue around people's sickle cell and the fact that this is not one of those conditions that is exempt when it comes to prescription charges. And I think because those who took part and helped co-produce recommendations felt certain elements, so for example, the issue around sickle cell and receiving medication was very important, that we had to have specific recommendations. So we've ended up with quite a wide range across the different lifespan. Next slide, please. So we actually have 64 recommendations across 13 themes within the 4 live courses. So there are 18 for the Starting Well live course. There are 17 for Living Well, another 17 for Recovering Well, and 8 for Aging Well. Next slide, please. This is the overarching principle that was read out earlier, and I think it's really important that in all the discussions, it was necessary that we had this, and this is at the beginning of the recommendation, and it's something that's emphasised that needs to be thought of and put in practice as you go through looking at the recommendations and trying to implement them. The recommendations have some that are specific to the London region, and these are highlighted in yellow. There are some that are at a local level, and these are not highlighted at all. And there are some which have national implications. The next slide, please. So in terms of the national level recommendations, it's difficult to do recommendations just for London, because in some areas when you're looking at health inequalities, racial health inequalities, there are some things that are going to be implemented from a national level. So if we're looking at maternity, and we all know around the poor maternal mortality rates by ethnicity and stillbirths, etc., these are national level interventions that are then implemented at a local level. So within 3 of the life stages, there are national level recommendations, but they have implications for London. So that is the first thing you will see when you look through the recommendations. So these are identifiable. Next slide, please. Because there are so many recommendations, we've put in a template, a matrix, to help people navigate the recommendations. So it shows you what the recommendation is, the different partners, organisation, collaborators that would need to be working together for each of the recommendations. So for recommendation 1, it'll be local authorities and integrated care boards. Next slide, please. So this is the draft recommendation I showed earlier. Next slide, please. And this is a revised recommendation. So there's a specific activity around taking forward existing recommendations, and then it's more specific in terms of the different organisations who are named and the different actions that needs to happen to implement that specific recommendation. Next slide, please. So I'm only going to cover a couple of these because I've been given my 2-minute warning. So this is the actual layout of the recommendation for each of the live courses. So this one specifically looks at special educational needs and disability. You've got the strategic aim, which is around reducing racial inequalities for the children and young people who've got special educational needs and disability, and ensuring there's appropriate provision in terms of education and training opportunities to equip them for adult life. You've got the objective, and then we have the different partners who we suggest through their role in supporting children with special educational needs and disability, who should work together. And then you have the different actions. So there's an action around service review, there's an action around taking forward existing recommendations, as an action around more engagement. So looking at how Black, Asian and minoritized ethnic parents are involved in the development of local dashboards, which should be in every local authority under the local inclusion plan. Next slide, please. Criminal justice. So this is one of a recommendation where you can see there are highlighted sections. So the highlights are for regional London-wide organisations. So we've got the Metropolitan Police, we've got MOPAC, and so there are some activities for local areas and some activities for regional organisation. Next slide, please. Similarly, this is just giving you another example where the actions are highlighted in terms of the activity, co-production, information, and so on. And this actually should be much clearer than the original draft co-produced recommendations that we had when we developed 52 to begin with. Next slide, please. So I'm now going to just, sorry, move on to the next slide. I'm just going to do some reflections from the co-produced recommendations process. So we did some evaluation afterwards, and I know Tuma's told you about her experience. We've had others who's talked about how, you know, it was really engaging. Yes, there was a lot of reports to read. There was a lot of discussion, but essentially this person is saying that, you know, there are a lot of recommendations, but essentially it's around delivering and measuring the impact. Next slide, please.
Tracy, last slide.
Oh, it will be, Jabir. Reflections on the co-production process. I'll leave you to read that. But what we wanted was both for everyone who took part to feel they had equal role. And you can see that from the statutory sector, the concern was that because they're represented the statutory sector, they may have more of a say and maybe outweigh someone who had a lived experience. So that's my last slide. But what I do want to say, just to conclude, is that you can appreciate trying to co-produce recommendations from a range of stakeholders with different perspectives, different priorities was a challenge in itself. Everyone found it difficult to prioritise, and I think that's really because of the nature and the complexity of structural racism, and they felt every area was important to specify because every area actually needed to have an action and it needed to have accountability. So that's how we ended up with 64 recommendations, and the real focus is all around collaboration, how London organisations can work together to deliver these recommendations. And I think that's the next slide is just the recommendations. Thank you.
Thank you, Tracy, and apologies for everyone. We're running slightly behind time, but Safia, you are going to get your full 10 minutes. So please hold on while we take some questions. Some really interesting questions in the Q&A, and I'll come to them in a minute. But I think there's one that I want to kick off with. Jessica, Tuma, and Tracy, you've all highlighted the wider issues that need to be addressed if we're serious about tackling health inequalities. And I wonder if perhaps starting with you, Jessica, you could say a little more about the wider determinants and the importance of starting there as well as thinking about the health system.
Yeah, absolutely. Before I do, if I might just say congratulations on the recommendations and the whole process. I'm so impressed. You've done a brilliant job. It's really complicated. I know from years of experience trying to make succinct recommendations, it's really challenging, and I've loved the way you've laid it out, and it's very clear, and congratulations. In relation to the question, Jabir, all the evidence shows that most of our health is shaped by factors outside the healthcare system. Now, obviously not all. There are still deep inequities in access and experience of healthcare services, and we've seen that referred to today for particular ethnic minority groups, people with disabilities, and other ways that they're discriminated against in the healthcare system. But notwithstanding those inequities, most of our health is still shaped by factors outside of the healthcare system. So all the evidence has shown that. And that's why we have those Marmot 8 principles I referred to. But there's still very much a focus on the healthcare system from the Department of Health and, of course, from the NHS itself. So we work a lot to try and broaden perspectives about health so that people understand the importance of thinking about health in relation to housing, early years, education, employment, pay, benefits, etc. All these factors outside which have such a profound impact on our health. And when you hear Wes Streeting talking about prevention, that's quite different by what we mean about prevention, really, where we're thinking about reducing inequalities in those social determinants of health. I think he's talking much more about access to screening and more traditional public health. So we've been advocating for a very long time to try and get the focus back onto those social determinants of health. It's good for the healthcare system. It reduces demand and need for healthcare, hopefully. And obviously it's good for all the individuals involved and all the other types of services, reducing demand. So we've been trying for a long time to make that case. And by the way, I was also pleased to see, Tracy, when you outlined just then, some of the recommendations that so many were for the local authority, which do have, and the national government, which do have these levers to try and make a difference in those areas.
Thank you, Jessica. Tuma, did you want to come in on that?
I guess my only thing was, about well, I had a point about like disaggregated data. So like when we were looking at some of the charts, could we like then look at it in terms of also disability? So to see where things are exacerbated in that sense. And so that was one thing that I was thinking about. I think in terms of the wider context, my honest opinion is that we could have a webinar on any of those areas that Jessica mentioned, housing, for example, and disability, and see how it could impact on poor health outcomes or difficulty accessing. But for example, one thing that I think about a lot is autonomy and control, and how we do have some impacts in terms of like what we do in terms of our health, but those are stripped from us if we rely on a social care system that kind of removes our autonomy and our choice and control. And there are some very, very straightforward practical things that could be done immediately that aren't in place. So I talk a lot as a feminist about disabled women's access to smear tests, for example. Why is it that we don't have hoists in GP surgeries? And so people that can't transfer onto the bed struggle to get a smear test within the recommended time frame. It's a very straightforward, quick thing that we could do. So yeah, I do think that there are some like almost quick wins in the wider context that could have an impact on the health, on the area of health.
You're on mute.
Thank you for that, Tuma. I am going to try and take some of the questions from the Q&A if we can. Tracy, perhaps with you for the first one. It says about the co-production process, but what are the levers or the incentives to act on these recommendations?
Well, I would hope that the levers are that, I mean, there's a financial lever, because essentially, I think Tuma, you said earlier on about the cost of healthcare and for disabled people. If we actually take a preventive approach, we look at prevention, that should then reduce the actual amount of time, the costs for people later on down the line, because we've not taken a preventive approach. I think the levers are that the majority of the organisations that are mentioned throughout the recommendations, so we've got local authorities, public health, we've got ICBs and so on, they have an obligation around addressing health inequalities. So there are levers already there that the organisations can be using, but I think it's about making them more accountable. And I think if, and I've seen, just don't want to take up too much time, but I think if communities and voluntary sector organisations, advocacy organisations actually get involved with the recommendations, that'll be a way in which you can challenge and ensure that the organisations who have the influence are made to be accountable for the actions and delivering on that.
Thank you, Tracy. Jessica, the GLA was behind your review and also behind this work. Do you think having the involvement of local government like that makes a difference, or is potentially one of the levers?
Definitely, I think so. I mean, the GLA have taken the evidence report, I hope recommendations that you've co-produced, and really tried to, develop them and implement them. So that's a very good starting point, and that's the right place to start. And of course, now there's lots of other stakeholders who need to be aware and to take action. I mean, we've got a fairly simple model of change, I guess, which is that you make the case, you show the evidence, you make people aware, you overview the levers for change, and there is legislation around this. There are duties on all these organisations to aim for greater racial equity and reduce other types of discrimination. So they do have an obligation, but it's often overlooked. So it's really highlighting that and just trying to push to make them accountable for the impacts that they have. And I will just flag up, though, I do think that employers, both private sector and public sector, but I'm thinking particularly private sector employers, do go under the radar a lot while we're all thinking about the stakeholders. So they do need bringing into this because there are lots of problems there with employment.
Thank you for that, Jessica. Obviously, the ethnicity pay gap reporting consultation has recently closed, and it'll be interesting to see how that takes you forward. I don't think we can let you get away without you saying something more about the changes that are going to happen to PIP and what that potentially means, and whether what's happened in the last day or so has made any difference.
Yeah, it's so I think one thing I really thank you, Jabir. That's my absolute hobby horse at the moment. But the narrative that's being talked about in the media, I think, is slightly off, in my opinion, because I think what needs to be made clear is that PIP is not out of work benefit. It is a benefit that kind of acts as a gatekeeper for other services. So, for example, to apply for a Motability car, to apply for a Freedom Pass on public transport, to access other support around disability, you evidence your disability through your entitlement to PIP. And so without that, you kind of close off all these options of support for people. And currently, these are the biggest attacks on disability welfare in many, many years. Even the Tory government didn't actually kind of go for PIP in this way. So it's quite a shock to the disabled community. What I will say I'll give an example, that you get more points. So it's based on a point system, and you get more points if you need help washing from the waist up than you do from the waist down. So as a kind of thinking about this from a gender perspective, how does that support disabled women to attend to their menstrual needs, their personal hygiene needs? It's really confusing, like who's decided these kind of really intricate details that seem to kind of disadvantage, and I'm not even sure that it's been thought through. It just feels really it doesn't make a lot of sense. But to even split the body into parts and assign more points to one part of the body than another is ludicrous. So yeah, a lot of people are going to struggle. And like I said, kind of Scope, for example, have look at the additional cost of being disabled, and it used to be kind of £500 a month a few years ago, and that's gone up drastically with the cost of living crisis. So things that people pay for, for example, a very specific tailored wheelchair like the one that I have, which prevents pressure sores, allows me to transfer into public bathrooms that don't have good facilities. That's all paid for. It's a private chair. The cost provided by the NHS doesn't cover the full extent of equipment, for example. So we need PIP to cover those additional costs. Yeah, and without it, people are going to be sicker, poorer, and really struggling.
Thank you for that, Timo. Nosheen and Vasia, we will make an attempt to answer your questions, but we really do need to move on and give Safi an opportunity to speak now, particularly as I think Safia's focus on public health is going to be a key part of addressing some of the questions that have been raised. Over to you, Safia.
Hi, everybody. My name's Sophia Meccano. I'm the Programme Manager for the ADPH London Public Health Tackling Racism and Inequality Programme. So just to give you some background, the Association of Directors of Public Health in London represents public health directors in the 32 London local authorities and the City of London. And the aim is to help directors come together where there's synergy to kind of do joint efforts of work to enhance their ability at above borough level. As we know, COVID was the greatest public health challenge of our time, where we saw disproportionate health inequalities amongst Black, Asian and minority ethnic communities. This exposed deep-rooted social and structural health inequalities. And as a result, ADPH London released a position statement. Can you just move on to the next slide, please? The next slide, sorry. Okay. ADPH London released a position statement in 2021, which highlighted racism as a public health issue. And alongside that, developed a programme of work, which has 5 different workstream areas, which are listed on the right-hand side. Each of those workstream areas has a lead who is either a consultant or a director in public health leading the work. So just to move on very briefly, just to touch on, could you go to the next slide? So part of the recommendations of the IHE report last year, the call for public health is for public health to take a leading role and to coordinate action around identifying the impacts of racism in health and the social determinants, and to put racial equity at the heart of policy and interventions. Next slide, please. And some of the ways in which public health, whether it's our programme of work or the wider system, are working towards achieving equity and starting to take a leading role and demonstrating our commitment to reducing health inequalities. I've highlighted here, so I won't read all of the items, but just to list a few. So in terms of starting to build the evidence base, thinking about research, so commissioning research and integrating research on how structural racism contributes to poorer health outcomes. So our programme, for example, has recently commissioned 2 pieces of research. One is an anthropology-based piece of research to think about trust and cohesion and how we as a sector or a system start to think about how we become more trustworthy to communities and how we work more closely with community groups. Also in regards to building the evidence base, thinking about pathways and the scale of harm and how we mitigate against further racial disparities, and also identifying and mapping interventions which help us draw upon specific frameworks to support the workforce in doing anti-racism work. Another area of our focus is how we improve ethnicity data, so improving the quality and completeness of data. So thinking about the accuracy in collection, also the granularity. So I think as somebody mentioned earlier, in terms of thinking about the categories, are they specific enough? Do they even reflect the London demographics? And if they're not reflecting the London population, then essentially we won't be able to provide the right services. So making sure that we improve that and help that to guide policy development and service decisions. Also supporting the public health workforce, but also the health workforce to think about the collection of data. So we've started to think about training frontline staff in terms of how they collect ethnicity data. Are they asking the right questions, comfortability, and so forth. So that's a piece of work that we'll be focusing on moving forward. One of our other work streams is focused around embedding public health in social and economic policy. So being a critical voice in terms of policy and advocacy, and also thinking about how we embed anti-racist principles into our public health policies to help us dismantle systemic barriers and explicitly continue to kind of highlight racism as a health determinant. Also thinking about community engagement and our partnerships that we're developing. So thinking about the wider system and who we need to be engaged with to ensure that we're working holistically to address the issues, and also making sure that we are centering the community voice and shifting power, so that we're not just consulting community members and community groups when it comes to consulting, but we're actually co-designing services, and that includes commissioning processes as well. So developing anti-racism commissioning frameworks. And just in terms of the workforce, thinking about how we improve the workforce who are delivering public health work. So making sure that it over time becomes representative, and supporting the faculty in regards to that kind of pipeline, but then thinking about what we can do in public health in terms of our local team. So when it comes to interview EDI processes locally, what are we doing to kind of improve disparities and equipping the workforce as well through training. And on to the next slide, please. And just in regards to some of the specific co-produced recommendations. So as Tracy mentioned, there are 64 recommendations, which is quite large. This list isn't exhaustive, but it represents some of the kind of discussions that have been taking place on a London-wide level in terms of priority areas, and thinking about in public health where we can kind of maximise our impact in terms of working in the London system with designated roles and responsibilities, but thinking about where we can kind of influence. So I've mentioned here around maternal health, thinking about mental health, long-term conditions such as cardiovascular health, and working in alignment with the Million Hearts and Minds programme of work, and also thinking about healthy standards of living for all. Sorry, guys, I'm in the office and there's banging. And I've just mentioned just in terms of how we will do that. So it's around kind of supporting the evidence base around what good or best practice is in this area in terms of implementing anti-racism strategies, also working closely with communities and co-production, service reviews where appropriate, improving ethnicity data, and also practice as well. So that's just kind of a whistle stop in terms of our public health perspective, and I'll end there.
Thank you for that, Safia. A really important and valuable insight into the public health approach. But in some senses, Safia, if I can just come back to you for a second, you're faced with the same challenge that Jessica's already highlighted, and some of the comments have highlighted, that we're looking at the health system rather than the wider determinants. Do you think ADPH has a contribution to make by getting us to think about the wider determinants and addressing those?
Yes, I definitely think so. I think being based in local authorities, there's a role for us to link into the wider local authority directorates, whether it be housing, adult social care and children's social care, for example, and think about how we're interlinking, working alongside and collaborating to make sure that anti-racism principles and practices are embedded throughout local authorities.
Thank you for that, Safia. Perhaps we can just take a couple of more minutes to address some of the questions that were raised. Some of those highlight what we're going to see happening in another couple of days with the 10-year health plan, which is one of the shifts that's meant to happen is a shift from into digital. I can never say it properly, but it's a key part of what Wes Streeting has been talking about. I wonder whether you think that's going to make a difference. Perhaps, Tumu, if we start with you.
Sorry, my mic wouldn't unmute there. Could you just repeat the question for me?
The question was whether the NHS's shift from analog to digital will impact ethnic minority groups, considering factors like low digital literacy and low digital access. Do you think that shift to digital is going to make a difference?
I'm not sure. I think there was already a shift during COVID, and I think for some people that made things more accessible. I think it was frustrating to see that some of the access features that people had asked for a long time and were told were just not possible became very possible during COVID. So we were given a choice. I guess it's about choice, isn't it? For some people, digital is more accessible, and for others, it's not. And it's about not being all pushed into one option, I think. And yeah, thinking about it as access. So yeah, how do we kind of provide alternatives and different ways of accessing things for different people?
Tracy, there's a question in there as well about in the changes that are taking place. How can we push anti-racism work forward in the NHS, given the major changes that will be happening in the next year or so?
Can I just add something to what Tumi was saying first around digitalisation? I think, yeah, choice is the key, but I also think that given that we know some minority ethnic communities are quite poor, you know, having access to the actual infrastructure as well as, you know, Wi-Fi, etc., is going to be a real challenge. And essentially, I always want to ask the NHS, are you going to provide everyone with a new smartphone? Because essentially that is what people need in order to engage. But just to go back about the changes, I think it is really challenging, but we can't forget that there are obligations. There are obligations around the Equality Act, there are obligations around addressing health inequalities, which the NHS, as well as other statutory organisations, need to make sure that they are abiding by and putting interventions in place. I do also think that there, you know, it was mentioned earlier on by Karen, we do have the London Anti-Racism Collaboration for Health programme, and that is to try and ensure that there is an anti-racist approach that organisation embed within their structures, within their systems, as a way of addressing health inequality. So there is something around implementing approaches, sharing and learning from and with each other. So we are all working together from the same page. So there are ways around this. So I think, yes, there are the changes, but there are things that could help.
Thank you, Tracy. And the last question to you, Jessica. Quite early, and I think it's been repeated in almost all the presentations, there's an issue about data and disaggregation and the availability or quality of that data. I wonder if you could just reflect on where you think we're going with data, particularly data that lets us understand the experiences of ethnic minorities in London.
Yeah, I mean, I think there are enormous gaps in the data. And I think I saw in one of the comments, someone said, can we further disaggregate by different ethnic groups? We try in our evidence review, we tried to use as the broadest possible ethnic categorization, horrible word in itself, but you know, there's enormous limitations. It's very difficult to capture, as Tibu was pointing out, the intersectionality within the data, and it's just not available. It's not that it's impossible to do. So I think there needs to be a big push on that. Now, the data only gets us so far, but it does at least enable us to highlight where the inequalities are, to make the case, to point out, to confirm what people already experience, and then to build on that. And without the data, it's really quite hard to do that. It also helps to monitor and evaluate. So it's really needed. London, by the way, has so much better data around ethnicity than other places. You know, there's been a big push on it. They do collect data, there's surveys and so on, which just aren't available in other places. So we need to really build up in the rest of the UK as well. But even within London, big gaps. Jabir, you're absolutely right. The ethnicity pay gap, how that's not been available before is beyond me. So let's hope that comes out of the next thing, and it's not, you know, brushed aside or put down to cost cutting or something, which would be terrible.
Thank you for that, Jessica. We've only got a couple of minutes left, and I do want to try just quickly pull together some of the threads of the discussions that have taken place here. Inevitably, when we've started to talk about health, we've ended up focusing on the NHS and the health system around the NHS. And if we're going to do that, it's important to recognize that there are some really significant challenges that persist to this day, and we often see it in the constant experience of late diagnosis, whether it's in cancer, whether it's with diabetes, whether it's with dementia. The fact that Black, Asian, and minority ethnic communities constantly have that experience of late diagnosis, and as a consequence, poorer experiences and poorer outcomes, points to something that needs to be changed and addressed there. But I have to also point out that in many ways the health system in the last 15 years has focused on racial inequality in a way that lots of other parts of the public sector hasn't done so. So we've not only had, I think, groundbreaking pieces of work such as the NHS 5-year forward view of mental health. If ever you get to look at that report, it's now quite old, but if ever you get to look at it, it's one of the few times where the national system has really tried to think through not only the evidence on racial discrimination for those people with poorer mental health, but what can be done to address it as well. That's been followed by other really key steps. The workforce race equality standard being made part of the standard contract from the NHS is groundbreaking, not only in this country but actually across Europe as well. It's never been done by anyone else before, so it's a real step forward. The commitment in the 2019 long-term plan to address continuity of care for Black, Asian, and minority ethnic mothers going through labour again was really forward-thinking. The fact that it didn't get implemented in the end is a real worry, but it was there, and it's part of the change that we want to see. However, it's also quite clear from today's conversations that we have to go beyond the health system if we're going to really address health inequalities, if we're really going to support well-being. And Jessica's highlighted, as have others, that without tackling employment and the experience of employment, we're unlikely to see the changes that we have. Many of you will have seen Brenda Hayanga's work, which suggests that minority ethnic communities are comparatively less likely to have long-term conditions up to the age of 40. But between 40 and 50, there's a dramatic turnaround. So by the age of 50, they're much more likely to have not only one long-term condition, but to have multiple long-term conditions. So there's something clearly going on there, and it echoes evidence from across the world of a weathering impact, and we have to address it. What I would say to you, and Tracy's highlighted, is the London Anti-Racism Collaboration for Health is a real opportunity for us all to work together. Please do look into it, and please do get involved. In particular, look at the Race Equity Maturity Index work that we're doing. Hopefully you can all play a part in that process as well. So thank you very much to the panelists today, Jessica, Tumu, Safia, and Tracy, as well as Karen setting the scene for us. Thank you all for participating, and do keep in touch with us, and we will follow up with some of the questions as well. Thank you again.
Thank you.
Thank you.